Yeah, so this is good to go. Good evening, everyone. At the outset, I would like to thank the organizer, Dr. Bansi Sabu sir, for inviting me for this. And since morning, this is a really interesting session. I hope everybody is enjoying this. And the most biggest difference what I find is in different conferences, you have a limited understanding of few topics, which goes in deep uh, length and breadth of that topic. But here what you are seeing is more of clinical approach, and it's an structured program. So that makes this totally different. So let's start. We are already running late. I am Dr. Mayur Agarwal, DMD&B Endocrinology from Central India, Bhopal. So without wasting time, my topic what is given to me is diabetes management in a special situation, that is pregnancy, elderly and in hospitalized patient. So this is actually really important topic. I would say even 45 minutes is not good enough, right? Because there are n number of guideline, n number of things which can be discussed, but I will try to summarize because our idea is to give you a brief concept of how this is done, right? So that is what we are going to do. So no financial disclosure for this talk, and as in India, we start with Badon ka Samman, respect the elderly. So I'll start with elderly only. So let's start with elderly type 2 diabetes. So let's see what I am not discussing, so that you keep these things aside. Okay, so what I will not be discussing is type 1. Now you see that type 1 can be seen in any age group. It's not that young patients or the young toddler, all those have type 1. We have patients diagnosed type 1 at the age of 50, 55 also. Okay, so that is not what I am going to discuss. Or other types of diabetes. Let's say a patient presenting at 75, he may have pancreatic diabetes. So that is not what I am going to discuss. Also, I am not going to discuss the complication which are already dealt. Also, I will not be discussing acute emergency, which would be dealt in the next few sessions. Okay, so what are we discussing and why are we discussing? Why are we discussing actually this topic in the elderly? Because elderly are totally different. They have different need. They can have frequent hypos. They can have hypo unawareness, and maybe they are not monitoring so much. They are living alone. The financial constraint is there. Maybe they are having tremor. They cannot take the insulin. They cannot prick themselves, they cannot check their blood sugars. So all those things are there, and then the sleep wake pattern is different in them, and then there are comorbidities along with this diabetes also. With aging, age itself is a comorbidity, you consider this. Okay, so this is an important thing. Age itself causes things to derange, right? So they may have BPH, and then you are prescribing an SGLT2 inhibitor, so that can create problem, right? Then patient can have polyuria, recurrent UTI, all those things can be seen in elderly. So elderly is slightly different, and all those things you need to keep into consideration while prescribing any medicine. It's not like you see the patient, you see the reports and you start prescribing. Important concept is to treat the patient, not the reports. Okay, so you have to examine the basic thing, everything, history needs to be taken, examination should be done, and then the investigation. Now what's the problem? That we are directly jumping on the investigation. We see HbA1c, we see fasting sugars and all those things, and we start prescribing treatment. It should not be done like that. Okay, now another thing which I'm not going to discuss in great detail is bone health and osteoporosis. So that's an important concept in elderly patient. Now can anybody say where you label as elderly? 50, 55 year, anything? Anybody? Yes. So somewhere it is 65, 70, but ADA says that 65 years. So that's an elderly. So osteoporosis, the recent guideline 2 years back, they were completely updated in the ADA 2023 guideline. And osteoporosis is a very important thing which should be screened in these type of patient, and 10 years or more of diabetes should be screened. Maybe you have a normal BMD, still the microarchitecture may be defective and the patient can develop fracture. So all those things need to be seen. And very important thing is hypoglycemia. If they develop fall, then they can have some say pelvic fracture, then can become bedridden, then the bed sore, then the UTI, pneumonia, everything can happen, right? So that is very important concept. Then cognitive issues I will be discussing. Polypharmacy is something very, very important. You should be looking at the whole prescription. Maybe somebody is prescribing them some drug which is already prescribed, say a cardiologist prescribing an SGLT2 and you are prescribing another SGLT2, something like that happens. Okay, so you should be seeing a complete prescription, because these patients have multiple complications, multiple comorbidities going on together, right? So you need to see patient as a whole. Okay, then the physical disability, all those things I will be discussing. This is from the Diabetes Canada. So overall there is a frailty assessment. You see here 1, 2, 3, that is very fit, well and managing well. For them I would say age is just a number because they are fit. Okay, you can consider them as normal. and you can keep them the targets as normal, whatever you do for a normal type 2 diabetic young patient, something like that. Okay, so that's important thing. See, you don't need to address everything, you need not check everything, it's not like that, but in general idea you should be having where my patient is falling. Okay, so very fit well, managing well is like they are doing everything by their own. Mildly frail and moderately frail where they need an assistant, and vulnerable is between these two categories where the patient may be doing by themselves but with some trouble, with some slow movements, all those things. And then this category is really important, that is 7, 8 and 9, that is severely frail, very severely frail and terminally ill. So accordingly we devise that what treatment should be given, what are the targets we should be keeping for them. So I'll come to that. So that's a basic concept which you should take into consideration while prescribing medication for the elderly patient. So cognitive dysfunction is there, maybe they are taking their OHs wrongly, wrong prescription, wrong timing, multiple OHs, maybe they are thinking this is OHA or this is an antihypertensive, they are taking it at the wrong time, all those things happen, maybe taking twice, thrice, something like that happens. So that needs to be seen. Okay, then self management task and the new knowledge attainment, that becomes tough. So don't give them very complex regime, you take this before this, after this will become a very troubling thing for them, and mainly they are dependent on caregiver. So caregiver should be taken into consideration, they should be told, because you may be telling them 100 points or maybe telling them 10 points and they remember only 2 points. So that's a common problem, so that need to be addressed. Okay, physical disability, you have to see whether they can do their routine activity or not and what you are prescribing. They may have hearing loss and you are keeping on telling them they don't understand anything. They have vision impairment, they cannot see their blood sugar, they cannot adjust their insulin, all those things happen, right? And then the falls is very, very important, as I have already discussed regarding the osteoporosis, and most of this patient would be financially dependent on somebody else, maybe their children, right? So that needs to be taken care. Don't prescribe them something which they cannot afford, right? So that's an important thing. Glycemic target, so this is really important and that's totally important in elderly patient. Okay, so this is from the ADA 2025, the recent guideline. You see here the HbA1c in the non-pregnant adult is less than 7% without significant hypoglycemia. If you can do it, that's the guideline. And for the elderly where there is limited life expectancy, then you may keep it somewhere 8. So that's the basic guideline from the ADA 2025. Let us dig deeper into this. So this is where your frailty index come into play. So let's say the patient is in first 3 categories, that is very fit, something like that. Then you can keep the same target, maybe less than 7 is good enough for that patient also, irrespective of the age. Okay, because physically he is very fit, right? All those things are there. Functionally dependent, you can slightly relax the target, and even relax the target if you think that the patient can have hypo or will not monitor, something like that, he is living alone, or maybe there is some cost constraint, he may not be checking his sugars again and again. So that is an important thing. Frail patient and end of life, especially end of life. Let's say a patient have, say, some malignant issue going everywhere, metastasis, you know the patient is not going to live for more than 1 month, right? So he cannot develop complication of diabetes. What is your aim is that he should not develop decay, he should not develop hypoglycemia. That is good enough, because you are not bothered about that he will develop complication, because he does not have 10 years to live, right? So that is important, that overall the life expectancy of the patient, right? So for end of life we don't target much. In fact, some of times if the sugars are like going 220 also, 250 also, it is okay. We allow them even taking some sweets also if the sugars are not going beyond 220, 250, something like that. Okay. So don't go very stringent in these type of category. Now this is from the CGM. Okay. So like your HbA1c, you have, I think this is not visible, just. Yeah. For your type 1 and type 2, you have your TIR, that is 70 to 180, you keep it more than 70%, right? Time in range, and time above you keep it 25 lesser, and time below range you keep it less than 4%. I think the basic things you must be knowing. The same concept what we have applied for HbA1c, the same thing we apply here for CGM also. What we don't want is hypoglycemia in this elderly patient. Reason being, the life expectancy is not that much. Any hypoglycemia can be end of life. Maybe he is walking through the, say, stairs and he gets a fall, he develops a fracture, or maybe in hypoglycemia he develops an MI, maybe he develops an arrhythmia. That is what you don't want. Ultimately you are preventing complication in the long run, but you are causing something very terribly acute thing, right? So that is not what you want. Same way we don't want hypoglycemia, so the TBR should be less than 1%, and we are compromising on the time in range because we want to reduce the TBR, right? So this even above 50% is good enough for the elderly patient. Okay, so this is very important. For old frail patient, keep your TIR 50%. Now this is something you need to tell your patient whenever you apply the CGM, because whenever you apply the CGM, any single reading goes higher, the patient is very worried. It's like a double-edged sword. Now he wants to know why my sugars are going 200, right? So for these type patient, don't go very stringent, because you would be causing more harm than the benefit to this patient. Now there are n number of things which can increase the risk of hypos in these type of patients. They may have renal insufficiency, they may have autonomic neuropathy, cognitive impairment, hepatic dysfunction, alcohol intake, and therapy with SU, sedative agent, polypharmacy. All those things can lead to increased hypoglycemia in these type of patient. So you have to see all those things also, what other thing the patient is taking, and the social support is very, very important, especially in our part of the country. Okay. OHS, something which you should be taking into consideration is, do not prescribe pioglitazone if you fear for osteoporosis. This can increase. If the patient is already in NYHA class 3-4, do not prescribe pioglitazone. If the patient has history of recurrent UTI, kindly do not prescribe SGLT2 inhibitor. We are talking in elderly. Okay. If there is a strong indication, we may prescribe that, but this is a general thing what I am telling you. If the patient is having recurrent hypoglycemia, kindly avoid sulfonylureas, and then kindly check EGFR, just not creatinine. You have to calculate EGFR. There are guidelines like below 30, do not prescribe metformin. 30 to 45, you may continue, but do not add metformin. And 30 to 50, you have to give at reduced dose of metformin. That's the basic thing. And then insulin, very important. They may have tremor, they may not have that dexterity, they may not have that acute, they may have vision problem. So keep it very, very simple. Ask them whether they can do it or not. Maybe if they cannot see, then they can count the click. All those things need to be addressed in these type of patients. Monitoring is something very important. Glucometers with a large display, without coding, easy to hold, bold numbering with memory, and CGM is even better in these type of patient. Now let's talk about diabetes management in hospitalized patients. So this is again very, very important. So why are we discussing? Again the same question. See, everything you do in your life has a goal, right? So why are we discussing this? Why we need a good glycemic control in hospitalized patient? That's a basic thing, right? So we need, because we want to prevent the metabolic decompensation. Maybe the sugars get very high, the patient land up into DK. Maybe the patient land up into HSS. Then there are studies that it is associated with poor wound healing. If the sugars are high, infection risk increases, length of the stay, that is hospitalization, that increases. Overall survival and the surgical outcome are also dependent on the glycemic control during hospitalization. So it's an important concept that you should be keeping the blood sugars. I will tell you the ranges. You should be keeping blood sugars in check. That is what I would say. Now there can be few possibilities here. Maybe the patient is known diabetic on treatment, maybe OHA, maybe insulin. Maybe the patient is known diabetic not on treatment, maybe trying alternative therapy, maybe just on MNT, okay, maybe just on dietary modification, maybe undiagnosed diabetes first time presenting in ICU or something like that, where you find that HbA1c is 13 and the sugars are like 500. Maybe it's an stress induced hyperglycemia, or maybe it's a drug induced hyperglycemia, because you have given something like, say, prednisolone, something like that you have given in the patient, and then because of that the sugars are going haywire, right? So these can be few possibility in your hospitalized patient. So let us discuss few of them. So previously undiagnosed is when you have an HbA1c higher, but if the HbA1c is normal and the sugars are higher, you say it either a stress or maybe a drug induced. That's a basic concept, okay? Now what are the targets? Very, very important. So if the patient have blood sugar more than 140 and you don't have an HbA1c, you should get an HbA1c. If you have an HbA1c within 3 months, that is okay, but if you don't have, you should get it. That's the first recommendation from ADA 2025. Then the target should be 140 to 180. Please remember this. This is very, very important number. This was changed 2-3 times, but for past 3-4 years, this is there. In 2022, they have kept one more line that you can keep it lower down, 110 to 140, provided you are not creating hypoglycemia. and here they have removed that number, but they have written that a more stringent individualized glycemic goals may be appropriate without significant hypoglycemia if you can do it. The number are removed, that is from recent 2 years, but in general it is 140 to 180. Okay. Now let us see in non-critically ill and in critically ill. So in non-critically ill, they have given a slightly wider range. Non-critically ill, probably the patient is eating. That is what they mean, right? So this is important. Now very important question, what are we going to discuss today is what should we give for the patient, whether we should continue with OHA, whether we should continue with OHA and add on insulin, or whether we should switch to insulin. That's the basic thing what you need to answer. A patient admit हुआ, what should be done, right? So let's talk about guideline again. So guideline says whether you're talking about a critically ill or non-critically ill individual, if blood sugars are more than 180 on 2 occasions with 24 hours apart, ideally you should be initiating insulin. That's a basic thing, but again it's a guideline. It is not mandate that you should be doing this. So let us talk more detail. Now let us first discuss that there insulin you can give either IV or subcute. There are some indication where you need to give IV insulin. So these are important things. If the patient is in DK, if the patient is type 1, if the patient is critically ill, not eating, if the patient is on vasopressor, if there is some peri-op thing, the patient is subjected for major surgery, if the patient is NPO or the patient is on TPN, all those things, then you should be prescribing IV insulin, because if you are giving subcute, probably it will not get absorbed, or maybe the pharmacodynamics will change, right? So that is important. And then there is an indication of severe hyperkalemia beyond sugars, and very important, if the potassium is less than 3.3, irrespective of your blood sugar, kindly do not start insulin. The patient may have AF, right? Very important. 3.3, even if the sugars are say 400, 500, you cannot start IV insulin. Now this is something very important. Anti-hyperglycemic in hospital setting, if the patient is critically ill, IV insulin, non-critically ill is still insulin, but you can give subcute insulin. OHAs are generally not recommended, provided the patient is admitted for very small thing, maybe a cataract surgery, you can just skip and you can reinitiate it, something like that, right? Or let's say the patient is admitted for just an endoscopy, you don't need to switch everything, just omit the morning dose, reinitiate. Okay, so we have very good guideline from the NICE. If you want, there is complete guideline for each and every drug. Again, we cannot go in that great detail. The basic concept here is to sensitize you what should be done, right? Now let's talk. I am giving IV insulin. How should I be giving it? What dose I should be giving it? How I should be changing it? So there are n number of things, right? So there is Portland, Yale protocol, Cup protocol, RBH protocol, and mind you, even the best super specialists cannot remember this. Nobody can remember all those things. Okay, so what we do is in every hospital we create simple charts, because see, you staff cannot ask every hour, now the sugars are this much, what dose is to be done. Ideally this should be done by the nursing staff. So you create your own protocol depending on the availability, depending on the resource. That is what is done. Okay, so the exact protocol is not very important. An institutional protocol or an hospital protocol is what is to be required, that is need to be developed, and probably that your staff should be trained to use that. That is more important. So if you see IV insulin, how you make it is 50 unit in 50 ml of NS, so you will get an 1 unit per ml of strength, and that you can give via the infusion pump, or maybe sometimes if you don't have then infusion pump, then dial set is something we use in resource setting, okay, resource limited setting, and the target is somewhere 140 to 180. You can give any of the regular insulin, any brand, or you can give a rapid acting analog. See, the basic difference in the analogs and your regular insulin, or let's say any long acting insulin, they've slightly modified, so the PK/PD changes. But when you're giving it in IV, it is directly going on the receptor. The half life is just 3 minutes. Why to waste money of the patient? Just give regular insulin. The regular insulin will come at the cost of 300. The analog would come at the cost of 500 or 800, right? So don't waste the money. Regular insulin is good enough. Insulin binds to the plastic tubing, so you need to flush, maybe 20-30 ml is good enough, and then the same you keep on changing, right? So let us see how you titrate. Initiation, there are n number of protocol. What usually is done is 0.1 unit per kg, a bolus is given. Again, that is very controversial whether to give bolus or not. Again, it's an institutional protocol. Infusion initiation, simple thing, blood sugar dependent upon 100, that is let's say 400, you start with 4. 350, you start with 3.5, something like that. That's the basic thing, initiation. Now, how to adjust? So, this is what we do. If you want, you can take the picture. Again, this will depend on institute to institute. So, if the blood sugar are falling say 30 to 50, I am okay. That is what we want. We do not want a rapid correction. The patient can have cerebral edema. Okay? So, 30 to 50 is good enough. And let us say the sugars were, and this is very important, like let us say sugars were 800, 900, which was not documented on your glucometer. Ideally, at the baseline, you should be giving a venous sample and you should be checking. Then only you would know that, okay, my sugars are falling by 30 to 50, because the glucometer report would be high, high, high. That's it. It will not tell you how much it is dropping. So, that is another important concept. And then ketone and all those things I am not discussing, that is again an important thing. So, let us say it is falling by 30, then you do not need to change. Whenever the sugars are high, that is above your target of 180, you just keep on the same rate. And if the sugars are falling by, what I have made it very simple, you remember it 25 and 50. If it is falling by more than 25 in normal range, you reduce it by 25%. If it is falling by more than 50, you reduce it by 50%. If you remember this line, it would be easy, otherwise nobody can remember again these charts. Okay. So, more than 30 to 50 it is dropping, that is 30 to 50 is okay, that is what we want, and the targets are higher, you keep on the same dose. And if it is 30 or say 25 to 50, you reduce by 25. If it is falling by more than 50, you reduce by 50, that is when the sugars are already within target range. Okay. And then less than 25, here it is 10, but less than 25 we usually continue same. That is the general thing what should be done. A Chinese proverb I would like to say here, मैंने सुना मैं भूल गया, मैंने देखा याद रहा, मैंने करके देखा मैं समझ गया. So, this is important for your hospitalized patient. I hear, I forget, I see, I remember, I do, I understand. So, until you do it, you cannot remember it. That's practically. Okay. Safety indicator, when you transfer the patient from IV to subcute, whenever the blood sugar are stable for 4 to 6 hours, the patient has no acidosis, no decay, ketones in the blood are negative, urine it may be still positive. Okay. So, blood ketone negative, acidosis is resolved, the patient is eating, the patient is hemodynamically stable, the patient is not on vasopressor, you just shift from IV to subcute insulin. Okay. Now, what is very, very important thing is overlapping. I have already told you IV insulin will work just for 3 minutes. So, as soon as you will stop, the sugars will keep on rising. So, you have to overlap for 20 to 30 minutes, you give the subcute insulin, you continue your IV insulin, and after 20 to 30 minutes you stop your IV insulin. Okay? So, that needs to be done. And then the dose calculation is, you can either calculate a 24 hours or you can calculate a 6 hours, and then you can multiply by 40, 80% of which you will use as subcute, 50% basal, 50% bolus. That is the basic concept. Okay. So, if you want, you can take picture, because I am very, very quick, because we want to finish within half an hour. Now, sliding scale is something which I thought I should be discussing. There are two things, sliding scale and the correctional dose. These are two different things. Sliding scale is, you give insulin when the sugars are higher. You do not give insulin when the blood sugars are normal. Okay. That is the sliding scale. Now, this should not be done, this is non-physiological. Now, what happens, let us say in the fasting the blood sugars were 90, you have not given any insulin by the sliding scale, the patient has taken breakfast, now the blood sugar went up to 250. Now, with 250 you have given say 4 unit, 6 unit, with that 6 unit the blood sugars are crashing to say 50. With 50 you have given something sweet or maybe some IV dextrose, the sugar has shot to 350. Now, at 350 again you have given 8 unit, the again sugars have gone to 30 and maybe the patient is unconscious. So, that keeps on happening. This is unphysiological, you should not be using sliding scale in any of your hospitalized patient. Now, what is the basic difference between the sliding scale and the correctional dose? Correctional dose, you give a dose of insulin at that normal value also, but you increase the insulin when the sugars are higher. So, that means at 90 or say 100, You will not give insulin in the sliding scale, but you would be giving in correctional dose, right? In correctional dose, you will giving a basal dose. Let's say I have written say glargine at night 10 unit and regular insulin 664. So 6 unit would be given at 90 sugars also. That's the basic difference. And let's say the fasting is 250. So in that time, both the sliding scale and the correctional dose, both will ask to give insulin, but there would be difference in the dosing. Okay. So correctional dose is allowable and advisable. Sliding scale is not advisable. Okay. The basic difference is that at normal sugar also the insulin would be given normally, and maybe you add just 0 unit because the sugars are normal, that is 0 correction, but you give insulin. In the sliding scale, you don't give insulin at the normal sugars. That's the basic difference. Okay. Now basal bolus is something which is superior, efficacious, more physiological. Basal will keep on a constant level of insulin, will maintain your sugars, and the bolus would be given depending on what meal the patient is eating and what the sugars are that time, because it would be different. Let's say the sugars are 100, it would be different, 200, 300, it would be different. The patient is eating 1 chapati, it would be different, 3 chapati, it would be different, right? So that depend bolus on what the patient is eating and what is his sugar at that time. Okay. Correctional dose I have already told you. Enteral nutrition, ideally you should not be using insulin in the TPN bag, but that some institutes are doing because it becomes tougher for it to adjust. Okay. So ideally continuous infusion should be going on with a different line and the TPN should be go with different line. That is ideally what you should be doing, but sometimes yes, in the TPN bag itself people are putting insulin and that goes like that, but that is not what is recommended. Tube feeding, basal bolus is something very important, and maybe say 2 hourly, 4 hourly also you can give insulin. So both the regimes are okay. I am not going into details of tube feeding also, because see, you aspirate and you see whether the remnant is there or not, and accordingly you will give the tube feeding, right? So accordingly you have to adjust the bolus doses. That's the basic concept. Now let us discuss hospitalized patient on steroid. So if the patient is on steroid, depending on the type, frequency, dose and duration, how much the patient is taking, the insulin would vary. If the patient is long acting, is on long acting steroid like the dexamethasone, probably you will you will require a basal insulin. And if the patient is on say prednisolone, your Visolon, Omnacotil, all those, then that half life of that drug will coincide with NPH. So in those patients, NPH would be preferred, something like 12 hour. Usually we give it post breakfast in the morning. You give insulin NPH at that time, it would cover. So whenever the patient is on prednisolone, you would have seen the blood sugar spike post lunch and pre dinner. That's the major spike what you see, and that would be covered with your NPH. Now let's discuss the peri-op management. So you have to initiate insulin beyond 180, the same thing what I have told you for hospitalized patient. Keep the target of 130, 180, and maybe 8% is something good enough to allow surgery, and this is from the cardiac surgery data. We don't have data for other surgeries, but that is what we imply on all surgeries. And depending on the type of surgery, indication of the surgery, whether it is elective or urgent, you decide that what should be done. Okay. Try to take this patient early. You don't want your patient to land up into starvation ketosis. 2 weeks of good control is something good enough. For minor surgery, you can allow. Metformin should be stopped maybe 1 to 2 days prior, SGLT2 maybe 3 to 4 days prior, and on the day of surgery, do not give any OHA depending on the surgery. Let's say you are doing just endoscopy, you just stop on the same day, you don't need to do anything other than that. So depending on the type of surgery, you decide that how much, whether to stop for 3-4 days, whether to initiate insulin or not. So again, there are recommendations, but again we cannot go in that details. And if the patient is already on insulin, something reducing the dose by 20% is good enough, and you have to monitor sugar, and depending on that you have to adjust your insulin dose in peri-op period. If the patient is NPO, he is not eating anything, glucose potassium infusion is what is required. If the blood sugars are more than 180, you can initiate an IV insulin. If the patient is NPO, no sliding scale in any of the hospitalized patient. And post-op, if the patient is eating, you can give a basal bolus. If the patient is not eating predictable, maybe you don't know how much he is eating, you can give an analog which you can give even after his eating. So there are some analogs which you can give post-eating also. So that is what you can do Okay, and then you can discharge on insulin or maybe oral therapy. If the requirement is beyond 0.5 unit per kg, you need a basal bolus. You should be initiating insulin, and let's say the patient is on got a CABG, major surgery. So you should be putting him on insulin for at least 2 to 3 weeks. That is what the standard protocol we follow. Now the last part and the most important part, diabetes management in pregnancy. Again, I will be very quick. So let's start with the definition of GDM. GDM is onset or recognition of first time during pregnancy, which is not overt diabetes. That's the standard definition. Now you see here each word. Recognition of hyperglycemia first time during pregnancy, that means it was undiagnosed prior. And overt diabetes is your cutoff, that is fasting plasma glucose more than 126 and your 2-hour plasma glucose more than 200 and your HbA1c more than 6.5. If two of them are abnormal, you label as that overt diabetes. If the patient is already diabetic, you label as diabetes in pregnancy, and there are some cutoff for GDM which I will be telling you. Now at the first antenatal visit, most of the guideline will say that you have to screen for GDM. Universal screening is what is recommended by most of the guideline except for the NICE guideline. Woman should be again tested. Let's say the sugars are normal with OGTT in the first time, then you have to again test at 24 to 28 week, and then maybe again you have to test if you see the patient is developing macrosomia or the patient is having polyhydramnios. Now this is what is diabetes in pregnancy. Maybe the patient is not on treatment, but your HbA1c is say 8 during first antenatal visit. That means it was undiagnosed diabetes. It is diabetes in pregnancy. GDM we have cut off. Okay, I will come to that. So pregnancy, previously known diabetes or undiagnosed diabetes in pregnancy is diabetes in pregnancy. Now what happens is the patient have some risk factor, obesity, ethnicity, nutrition, physical activity, genetic predisposition, due to which there is increase in glucose, triglyceride, free fatty acid and insulin resistance is there, and this leads to preeclampsia, preterm level, stillbirth, congenital malformation, LGA baby and birth trauma would be there because of the macrosomia. The patient develop hypoglycemia because of the beta cell hyperplasia, hyperbilirubinemia would be there because of the polycythemia, because of the large size, and then the respiratory distress syndrome can be there. So this is about your GDM, why we need to treat. This is the basic pathophysiology. Again, I am not going into detail. Because of the insulin resistance, you have higher blood glucose which goes via the placenta to the baby, which stimulates the pancreas, leading to beta cell hyperplasia. That is why the patient or the baby will develop hypoglycemia after the birth. Okay. So now there was concept of primary prevention, secondary prevention, tertiary prevention. Primary prevention is like risk factors are there, disease is not there. Secondary, when the risk factor disease is there. Tertiary, when there is complication. So this is primary, secondary, tertiary prevention. Now what we are talking about is primordial prevention. That means when the baby is within the womb, you want to prevent diabetes in that baby. That is what we are talking about today. Okay, so that is primordial prevention in the next generation, I would say. Okay, now this is very confusing. Take a picture and you revise it, then only you will understand. So this is diagnostic criteria and number of criteria. Let us talk just the very basic thing. If you understand that the DIPSI, the Indian criteria, they are very simple. We are resource limited setting. What we do, non-fasting patient, you give 75 gram. If more than 140 at 2 hours, you label as GDM. Less than 140, normal. No much thinking beyond that. Okay, that is very clear. Now let us talk about the IADPSG and the ADA, WHO, ES, FIGO, all those guidelines. Here what they do is one step, fasting 75 gram anhydrous glucose, and if the fasting is more than 92, 1 hour more than 180 or the 2 hour more than 153, if any one of the three is abnormal, you will label this patient as GDM. Okay. Now the ACOG comes with two-step. Two-step, they say that you give first in non-fasting, you can give 50 gram of anhydrous glucose, and if that is beyond, there are different cutoff, 130, 135, 140, you take as 140. So if that is more than 140, you do a two-step test then. In two-step test, you don't give 75. Now you will give 100 gram and you will monitor for 4 points, 0, 1, 2, 3, 95, 180, 155, 140. And if 2 are abnormal, then you will label this as GDM. So what ADA did in 2020 is that they took both the cutoffs, both the guidelines they have combined. Either you can go for one-step test, which is 75 anhydrous glucose, or you can go for two-step test, that is 50 followed by 100 gram. If 50 is normal, less than 140, you don't go for the second step. Okay. So this is regarding the diagnostic criteria. Screening universal is recommended by most of the guideline, but UK NICE don't recommend this. Screening 2-step is by ACOG, ADA accept both, whether you can go for 1-step or 2-step, that is okay. 75 or 100, 75 in both, almost all the guideline, 100 in your ACOG, and then depending on what cutoff you are taking, point sample, fasting, non-fasting, I have already told you, maybe 1 sample, maybe 2 sample, which cutoff you are taking, which criteria you are taking, depending on that you will label this patient as GDM. Okay. Now this is very important, this I have taken from Amazon. Can anybody say that how to measure 75 or whether this glucon D 75 can be given to the patient for checking OGTT or not? Just raise your hand in yes. Can you just measure 75 gram of this and can you give that? Very good. So yeah, I can enlarge it. So you see here, per 100 gram, if you see the carb is 90 gram. Most of us would have never read this label. Okay. So when you give 75 gram, it is not 75 gram. The correction factor is 1.1. That means you have to give 82.5 gram to make it 75 gram of anhydrous glucose. So if you are using this thing, which is available commonly, this I have taken from Amazon only. So you have to give the patient 82.5 gram. See, when you are doing so much of thing, when you are taking fluoride vial, when you are labeling that, okay, 140 I will label as GDM and 139 I will not label as GDM, right? You are going for that accuracy. So you need to measure this accurately. That's an important thing, right? And then there are some medical legal aspect of the same. Now let's talk about targets. So in pregnancy, the targets are totally different. Pre-meals, whether you talk about fasting, pre-lunch, pre-dinner, it is less than 95, 1 hour is less than 140 and 2 hours is less than 120. You can take the picture of this also because this is important slide. Similarly, for your CGM, the targets are different. For CGM, you see here the time in range, the cutoff are totally different. You see here it is 63 to 140. I will just enlarge. 63 to 140. It is not 70 to 180. And for type 1, we have data to keep it more than 70%. And for type 2, we don't have data. So the recommendation says keep it high as possible. Okay. So without causing hypoglycemia, if you can maintain this range, that is what you need. 63 to 140 on CGM in type 2 patient already or GDM. Type 1 we have different, we have studies for that. Overview of the management of GDM or say diabetes in pregnancy is important thing is obviously MNT exercise if allowed by the gynec. Maybe if the placenta is lower down, the patient will not be allowed exercise. All those things you have to keep in mind. And then the very important question is metformin versus insulin, oral therapy versus insulin. I will be discussing and monitoring and the fetal surveillance, how to do it. So MNT again, it depends on the pre-pregnancy weight. If the patient is obese, you don't allow too much of calories, and this is for the singleton pregnancy. If you have twin pregnancy, this data would change. The energy requirement would change. This is for singleton, single baby inside the womb, and then depending on the pre-pregnancy weight, pre-pregnancy BMI, you decide how much calories you have to give. Metformin, again very controversial. If you say both metformin and insulin comes in category B, that is we don't have much studies here, but whatever we have, they say that it is safe. We don't have dedicated RCTs, all those for this. It is non-teratogenic, safe even in IVF pregnancy, and earlier 2014 guideline also approved metformin and glibenclamide, but recently this is not an approved treatment, especially it's not first line treatment. Okay. ADA don't recommend to use this any metformin or glibenclamide. If you see metformin, it reduces the risk of preeclampsia for sure. We have very strong data for that. Reduces the risk of large for gestational age baby. Okay. So we have, but SGA baby, it can increase the risk, no increased risk of any congenital malformations. So we have MIG trial, metformin in gestational diabetes. No role in prevention of GDM, because sometimes what happens that PCO patient keep on taking this. Maybe you can reduce the risk of preterm level. We have some data, especially the first term miscarriages, that can be reduced, but there is no role of prevention of GDM. Overall, there is less pregnancy weight gain when the patients are on metformin, reduced dose of insulin. If you are giving metformin along with insulin, and then the less risk of hypoglycemia because you are reducing the dose of insulin, and maybe the less risk of neonatal hypoglycemia because you are overall reducing the glycemic. Okay, so glycemic load is reduced. Better patient acceptability because you are comparing here an injectable therapy versus an oral therapy, but higher failure rate, that is from the MIG tofu trial. Okay, so MIG is your metformin in gestational diabetes, tofu is your the offspring follow up, TOFU. So these are two trials actually, I have combined them. So 750 GDM patients were taken, and metformin versus insulin alone, metformin plus insulin versus insulin alone. There was no difference in the neonatal outcome. Hypoglycemias were lower in metformin because low dose of insulin was required. When you add metformin to insulin, preterm birth delivery, that was higher here, and children exposed to metformin at 2 year and 7 year, not much difference was seen with few parameters. I am not going into details, but at 9 years there was significant difference. So probably the baby is born with lesser weight, but that gains rapidly. That is what this trial is showing us. Now let's talk about insulin. So Lispro-Aspart regular insulin is approved for the longer acting NPH, and Detimir is approved. Glargine can be continued. Do not initiate in glargine in those patients who are GDM, and Degludec has been recently approved in these patients in pregnancy. Now let's talk about steroid in pregnancy. This is just last 2 minutes, I would say. So ensure glycemia is well controlled before giving steroid. If possible, increase the basal dose if the patient is already on insulin. Correction dose is needed as per requirement depending on the sugar, right? Monitor glucose more stringently. A CGM would be even preferred in this type patient, and maybe some 3 to 5 days is what you see the effect of steroid. You will require a higher dose of insulin. HbA1c in pregnancy is fallacious because of the hemodilution, but in first and second trimester we have data that it is associated, it has some correlation with the fetal loss and malformation, and ANC measurement of this HbA1c should be repeated in the first trimester. Okay. Fetal monitoring, you have to look for macrosomia, and that is through your abdominal circumference. If it is more than 75 percentile, a more stringent sugar control is required. Now let's talk about the labor. So high rates of preterm in GDM is spontaneous abortion because of preeclampsia, nephropathy and the obesity, and usually gynec would say that at 38th week, when the fetus is mature enough, you should go for either LSCS or induction of labor is also possible. It's not that all these patients should be subjected to cesarean section only. If there is indication for cesarean, it's not the glycemia. Okay. Neonatal management, hypoglycemia is what you should be looking at, hypocalcemia, RDS, hyperbilirubinemia, macrosomia. Usually the definition is more than 4.5 kgs, but in India what we say is 3.5 kgs because our babies are usually lesser weight. And then the congenital heart disease also increases. So all those things need to be screened in these babies. Postnatal management, for the pregnancy, you should allow breastfeeding. Usually metformin is excreted in the breast milk, but it is pretty safe. OGTT should be repeated in 4 to 12 weeks, and then every year for lifetime you should be screening, because these patients within 30 years, that's what the data says, almost everybody will develop type 2 diabetes. So lifestyle modification and MNT is what we say to them, especially once they wean off breastfeeding, then you can restrict the calories. Okay. So risk of future GDM and type 2 diabetes should be discussed with this patient, and pre-conceptional care for the next pregnancy should be told to them in great detail. Thank you very much. I have taken much time.